Dr. Nemo, can you hear us?
Yes, very well, I can. Good evening.
All right, so we'll just give some introductory remarks and then you can start. So again, I want to apologize for the delay in starting due to technical issues, but we are here now. So once again, I'd like to welcome us on behalf of the NSCRD and the Board of Trustees to the April edition of our monthly meeting of the Nigerian Society for Colorectal Disorders. And we were supposed to have a different presentation today, but unfortunately, our speaker had to pull out at the last minute due to very stringent personal issues. And we are glad that Dr. Vincent Endemo has taken up the responsibility of making sure that we have something to discuss today. So we have an interesting case presentation and a discussion by himself. And without further ado, I'll give him the stage to continue. Dr. Nemo, please continue.
Thank you very much, well-respected presidents, our past presidents and international scholars and distinguished members. So this particular patient is still in the ward. We want to present him today so that we serve as a learning point for all of us in colorectal surgical society, and to be able to relate with what is done outside our clients with respect to this particular presentation. So our patient is Mr. A.N. He's a 32-year-old male artisan whose highest educational qualification was elementary school. Next slide. He presented with persistent abdominal pain and passage of bloody watery stool following a right heniography that was done 6 weeks prior to presentation on Monday. And we had a previous history of the passage of bloody mucus stool, which had persisted and has had transfusion of 3 units of blood pre-operatively and then 2 units of blood post-operatively at a peripheral hospital prior to presentation at our referral center. After the surgery, he had persistent abdominal pain, which was generalized, wasn't relieved by any known factor, worsened by movement, and then non-radiating. It was associated with high-grade fever, which was intermittent, and a generalized body pain, and then malaise. Next slide. When he presented at the emergency room, we found a young man who was in respiratory distress. The respiratory cycle of 28 per minute. He was cachetic and diaphoretic. He was markedly pale and had marked weight loss. He had bilateral fetal edema up to the thighs, had a pulse rate of 138 per minute and a blood pressure of 140 millimeters of mercury. His abdomen was distended, was quiet, and had tenderness and rebound tenderness. The bowel sounds were hyperactive. Fetal rectal examination had a normal prostate with postrum inconsistency with a preserved median sulcus. The examining finger was stained with mucoid bloody stool. Other systems that were examined were essentially normal apart from the cardiovascular, which we have talked about, and the abdominal examination and musculoskeletal. Investigations revealed a blood hemogram of 6.1 grams per DL with marked neutrophilia, WBC of 16,000, and a neutrophil of 89%. The potassium was 3.1 millimole per liter. He had a marked hypoalbuminemia of the serum. The liver function test revealed deranged liver enzymes. And sorry, mentioned it was actually jaundice. The analysis was normal. Next slide. We were only able to get abdominopelvic ultrasonography and erect chest film as well as plain abdominal X-ray, erect and supine film. The abdominopelvic ultrasound that was done by the emergency doctors on call revealed a dilated edematous aperistatic bowel with minimal echo-rich fluid in the pelvis. There was hepatomegaly and grade 1 nephropathy. Next slide. the abdominal X-ray, the erect chest film was essentially normal. While the abdominal X-ray, erect and supine film showed dilated small and large bowel. Next slide. We made the diagnosis of peritonitis secondary to bowel rupture. And our plan at that particular point was to resuscitate the patient via fluid and electrolyte correction to optimize his hemogram and then to prepare him for surgery. So after this were done, the patient was wheeled to the theater 16 hours after for an emergency exploratory laparotomy, which was done via a midline incision. The anesthetist opted to use a subarachnoid block, a regional block, because of the fact that the patient had very unstable vital signs and they were like you may get into a hypertensive emergency when they do a full G, and the fact that ICU didn't have ICU care, where the number of beds that were in ICU were already occupied and the patient was not going to get an ICU care after surgery. So they decided to take a chance and we had to operate via a subarachnoid block. So it was a midline incision, a little superior to the umbilicus, and the operative findings were presence of pus in the pelvic hole, the sac. There were markedly dilated anedematous small and large bowel with a single perforation at the antimesenteric wall of the transverse colon at about the midpoint. And there were fibrinoid exudates all over the small bowel, as well as the large bowel. So the attempts at, after sucking out the pus with suction, we removed the fibrinoids and made an attempt to close to inspect the perforation. And it was discovered there was a nodular mass around the point of perforation. And indeed, the finger that was insinuated into the transverse colon revealed nodularity all about that. So in view of that, we were thinking we may be dealing with a tumor, which prompted a search around the entire abdomen. And we decided to do a transverse colectomy, but it was discovered that at both ends of the resection margins were still the nodular masses. So we went on to do not a proper pancolectomy because around the hepatic flexure, the bowel, the transverse colon was adherent to the liver at that point, as well as the gallbladder and all the structures that the portal hepatis, and they appeared inseparable. Without fear of hurting the structures around that point, a partial resection of the large bowel was done at that particular point, and then we couldn't really dissect down to remove the entire rectum because at the particular point, the anesthetist was prompting us to get the patient out of anesthesia because his spinal had worn off and the gentleman was struggling. So our duty at that particular point was, as much as possible, to keep this patient alive. So we resected from the terminal ileum down to the cecum, part of the hepatic flexure of the colon, the entire transverse colon, descending colon, the sigmoid, and then part of the rectum. A Hartmann's pouch was created, as well as an ileostomy was done for the patient. This is a diagram of the resected part of the bowel. You could see, get to the next slide. Okay, you could see that because our pathologists at our center would usually advise after the surgery that we bisect the bowel from the antimesenteric body and then wash thoroughly before fixing in formalin. So you could see that these were attempts to conduct a pancolectomy, but various segments were resected separately because of what I had mentioned. It's really around the hepatic flexure where we encounter difficulties, and at the part of the rectum, we couldn't completely resect before we did the Hartmann's and the ileostomy. So we thought these patients, post-operatively, the immediate post-op care was instituted for the patient. It was a little turbulent, but the patient was able to pull through, and 2 days post-operatively, he was begun on orals, and then the antibiotics initially had to be escalated to the meropenems and clindamycin, and then he had some little inotropic support at the beginning, but essentially at this particular point, the inotropes been stopped. It was just 24 hours post-operatively, and the patient is still on the meropenem and clindamycin, and presently no longer on oxygen, and the ileostomy is functioning well. So this is please get to the resected sample, the one that is in beads. Okay, so that's the resected sample, and we thought this patient had a familial adenomatous polyposis coli, and then we have some questions that other differentials could be the mucosal associated lymphoid tumor, and then probably some part of the inflammatory bowel diseases. Well, it's left for this house. We do not have histological results at this particular moment. But there are questions we have. But lastly, the last slide. The questions are, is it advisable to attempt a colostomy in the face of peritonitis just to make a diagnosis? Then from our colleagues here on this call here in Nigeria, I want to know that, and then from outside, aside from the radiological investigations the patient couldn't afford at that point, as a CT scan, what other investigation would have been done for this patient in this particular setting to be able to achieve a good surgical outcome for this particular patient? My intention here is to stimulate a NIDOS for an academic discussion, and then to help us to also manage this patient who is right here with us in the ward, and then to help us to forge ahead in the event of having a poor resource settings where we don't have the diagnostic armamentarium and the cost to afford it. Thank you very much, distinguished colleagues, for listening to me, and then I'll wait back to take your questions and clarifications to be made. Thank you.
Thank you, Dr. Nemo, for this presentation, and thank you once again for accepting to make this talk at the last moment. This was indeed a challenging case. So I'd like to hand over to our rapporteur, Dr. Gwari, to moderate the discussion on this interesting case. Thank you, sir.
Yeah, thank you so much, Dr. Nemo. I think this is quite challenging, and I mean, we're also putting into consideration that the patient couldn't afford radiological investigations preoperatively, so you were really flying in the dark here. But my question, the first one would have been, I mean, this was quite a dicey case. Why did you just not, create a double barrel colostomy just to get out and fight another day? And at that point, you could have done a colonoscopy through the efferent and the afferent limbs to actually see what was going when the patient is stabilized.
Okay, thank you, sir. Okay, so the problem I had was what I intended to do when I saw those nodules was I thought I could just do a repair, and then you were quite friable. So in that particular, I was afraid mobilizing the transverse colon, which wasn't quite as mobile as it should be, would have been as it was. But in looking back now, if it was not as friable as it, I should have created that transverse colostomy for this patient, at least the most mobile part of the gut, or even an ileostomy. Looking at it, thinking of that's the risk that we're taking to salvage this patient.
Yeah, because you can see with the prevailing clinical picture of intraperitoneal inflammation with pus in the abdomen, hypoalbuminemia. Trying to anastomose would have been a disaster, first of all. So the only option you would have had was just this for the function of the patient. Again, this was done under an epidural, which meant that was not even an appropriate anesthesia for use. I mean, Guy, you did a fantastic work here, but looking at those pictures, that looks like pseudopolyposis to me. Again, if you put that in tandem with the clinical presentation of bloody diarrhea, so this would be something like inflammatory bowel disease. We have to wait for the histology to know exactly what the histology is, and with the friability, patients that have adenomatous polyposis coli will not have that kind of mucosal inflammation. But anyway, I'm just going to invite a discussion first of all, but I'm trying to see what people think about it and what lessons we need to learn, because you did a fantastic job, but it was really tricky. And the fact this guy is eating orally on day 2, that's a miracle. It's an absolute miracle. Yeah. And then it's gone up inotropic support and all that. So it's fantastic. Well done. Are there any comments or contribution? I thought Professor Ogo raised his hand.
Good evening, sir. Thank
Good
you, sir,
evening,
for your
Prof.
opportunity. How are you, sir?
Very well.
Thank you.
Okay.
Good. I think that this is a very tricky case, and I appreciate the effort of the managing team. However, I support completely what you had said. In the presence of sepsis, peritoneal sepsis, and peritoneal soilage, the guiding principles are clear. First, if there is need to take biopsy, you take your appropriate biopsy. And then you either do an ileostomy or a colostomy and come back when the patient has fully recovered and you've done the appropriate investigation, and you go in to do the operation you think will help the patient. I'm not quite sure that without a pathologic diagnosis, that one could decide what one should do concerning this type of polyps that we have seen. We don't know what they are. They may be benign for all it could be. Secondly, trying to repair a perforation in the presence of peritoneal soilage is not on. That repair is most likely would have broken down. And bearing in mind that this patient has hypoproteinemia, I think the best chance for this patient would have been to do take the appropriate biopsy, an ileostomy, a colostomy, in this case a colostomy, and put a drain to clean up the peritoneum, and then we'll see what happens. Thank you very much.
Thank you so much, Prof. Dr. Saeed Haqqani, you have your hand raised.
Thank you very much. Dr. Enebo, thank you for the presentation. I consider what you described with interpreting findings of the hepatic flexure plastered to the liver, portal hepatitis, and the gallbladder. Does that mean they see a segment of the colon attached to that place now? Considering we have ileostomy, we have atmans. We have a segment of the colon of the hepatic flexure attached to that area, and what is the fate if that is the case of that residual problem? Thanks.
There is, yes, there is a part of the wall, probably the particular wall that is opposed to those structures at that point at the hepatic flexure to attach to the liver, the gallbladder. They appeared extremely inseparable. There was couldn't get any purchase at all around that particular point. So we took part of the wall. We left part of the wall is left behind together with the polyposis associated with it, because the fear was trying to dissect that off the liver and the gallbladder, as well as the structures of the portal hepatitis would have damaged those structures at that point. So they are left behind.
Yeah. That's again, then to look at it, the other question I would be asking myself, if I was thinking this is cancer, I would rather want to leave the gut intact and block inside than disturbing it, because now that you've taken a bit of it out, if it turns out to be cancer, then this patient is going to have disseminated peritoneal disease. But I think this is, looking at the transmural disease in that colon and the multiple polyps, it looks like Crohn's disease and or UC with pseudopolyposis. I stand to be corrected. But one interesting question I want to ask, somebody did a herniorrhaphy for this patient prior to this. I think this patient may have had symptoms prior, and was anybody thinking of investigating this patient before the herniorrhaphy to see why he was cachectic, and the hypoalbuminemia? I also have no doubts that it may have begun before that herniorrhaphy.
Yes, sir. Can I make a comment, sir?
Yeah.
A number of comments. Again, thank you, Dr. Enemo, for this presentation. And this is very, very challenging. I think the first thing I want to say is that practicing in Nigeria in many settings is almost like practicing in a war-torn or a conflict zone, where the surgeon has to make up his decision with very limited information. You don't have access to advanced imaging. You don't have access to energy devices. You don't have access to intensive care supports. And so you just have to make the best of what you have available. So for us to continue to practice in that kind of setup is very, very commendable, but again, can be very stressful, both emotionally and physically, and also intellectually to the surgeon.
Mm.
The second point I want to make out is the fact that we are dealing with a patient who probably has one or two diagnoses. Either he has a malignancy or he has a benign condition. As has been said, the most likely benign condition would probably be inflammatory bowel disease, specifically ulcerative colitis. Most likely some form of toxic megacolon that led to a perforation in there. Now, the standard approach in that kind of scenario would have been to do a subtotal colectomy and an ileostomy to get the patient out. But that is more feasible if you have the intensive support and you have energy devices to quickly take out the bowel, detach from the mesentery, so that you have less bleeding and can save time. Unfortunately, we don't have access to that readily available. And that's why you now start thinking about other options and that would have been preferable. Now, the fact that the transverse colon, when the hepatic was attached to the liver, was a sign that likely if this was benign, there may be a focus of malignant transformation in there. And as Dr. Egora has mentioned, the ideal aim is not to leave any part of the bowel mucosa exposed in the peritoneal cavity. Already he has a perforation that, if this was malignant, has already upstaged it to stage 4 disease, peritoneal metastasis. But having raw peritoneal surface in there, if he may have seedlings into that will further worsen this condition. But at this stage now, it's just to save his life. So I think as a learning point, if we're comparing this kind of scenario, we have to see, is the bowel mobilizable or not? If you're unable to mobilize the bowel, the aim is source control. You take out a mobile portion of the bowel, whether it is the colon, transverse colon would have been this scenario. Even if it was tumor, the person is to save the patient's life. Bring it out, wash out the peritoneal cavity, put in drains, and give some form of resuscitation, and now decide on how to proceed. And in that kind of scenario, if we had the luxury of having an intraoperative endoscopy, could have also put in the scope down the stomach to have a look and see. So it's going to be very challenging this next couple of weeks, how this man will recover based on the trauma he's gone through. And again, Dr. Gore has also mentioned one important point. Many times we see patients who have had chronic illnesses having elective conditions like procedures like herniorrhaphy, sometimes appendectomy. Meanwhile, there was a more sinister condition masquerading in the background, and they may be treating those symptoms with the wrong procedure, and it makes the subsequent treatment very, very difficult. So again, I'd just like to admire your courage in taking this patient in. And then finally, just to say this again, that as primarily general surgeons, whether pediatric or adult surgeons on the call, we still have to have an open mind. The abdomen is like a mighty ocean that has many structures, many organs in there. Although that's one of the reasons why I like general surgery, because there's always a potential surprise. There's no routine in whatever we do. So, but we should bear in mind the fact that we could encounter patients with inflammatory bowel disease who may masquerade in this kind of presentation, and we should have ideas of how to approach them. I'm sorry for taking so much time. Thank you, sir, for the audience.
No, that's grand, Mr. President. Professor Shinawo, you have your hand raised.
Good afternoon, everyone. Is it good evening, everyone? He actually has said everything I was going to say. I think, but what the emphasis here is when a patient is clinically unstable. I joined a bit late, but I heard that the patient had peritonitis. It was an inotropic support, which I'm going to assume the patient was hemodynamically unstable and he has a generalized peritonitis, possibly due to a visceral perforation. I think in this kind of a circumstance, we should just try and do what is minimal. Maybe an ileostomy or a colostomy, wash the abdomen and go and sleep, because you are going to spend so much energy operating the patient, spend so much energy in the post-operative period managing the patient. You've been lucky so far that the patient is good, but you could still lose the patient. That's the reality. I think in all this setting, I think the take-home message in this situation is we must do what is minimal. Once the patient has peritonitis and is hemodynamically unstable, just fight the battle another day. Do what is minimal, keep the patient alive, and fight the battle another day. Now, I think it may be inflammatory bowel disease. I mean, a UC is most likely ulcerative colitis. We've seen a few cases like that. It's most likely going to be UC. So the take-home message here is we should always try and do what is minimal in this kind of context. Thank you, everyone. And kudos to you, the surgeon. And at least I'm very sure you must have been stressed operating this patient. Thank you.
Thank you so much, Professor Sino. Yeah. Like I used to tell my trainees, in situations like this, less is more, and I remember Bob Marley's song. It says, "He who fights and runs away live to fight another day." It's just always important for us to, remember that it's just because it's just too much heartache for us. You would have sweated so much to do this. It must have been a very challenging case. And for patients with transmural disease, maybe toxic megacolon, it could have been an inflammatory adhesion to the portal hepatic system. And you were again it was wise to not go and disturb the portal hepatis there, because that would have caused more trouble for you. But the other question I wanted to ask is, nutritionally, how is his nutritional status now?
Okay, so he wasn't able to afford albumin at the start. So what we were giving was amino acids. But he has started taking soup broth. He's able to tolerate meat and some other foods that are nutritious. So we complement that with histamine infusion as well as some other infusion. But he's tolerating orally now. So this is 5 days post-operatively at this particular moment. So we've not really rechecked the serum protein, another nutritional assessment, but he's up out of the bed, not fully ambulant, but out of the bed as it is, to sit on seats and then come up with support.
Okay, that's
good access at the moment.
Can I make a comment on that, sir?
Yeah.
Yeah, thank you, sir. Again, it's a very challenging issue when you don't have access to a nutritional team and total parenteral nutrition. But it's good that this patient is tolerating orally, and high protein, high calorie diet with multivitamins is very important for him, because his immune system is still down the rails with what has happened. The other concern I have for him is regarding the stomach output. Bear in mind the fact that there's an ileostomy, and bear in mind that we're in a tropical setup where fluid and electrolyte imbalance is a big problem with ileostomies. And how are we controlling the high output for him in that kind of situation?
Okay, he's still on IV fluid, and then we can actually estimate the electrolytes every 2 days, and then we correct the fluid as much as he's losing. We try to augment and still taking the urine output.
Are we thinking about using any anti-motility agents for him? Like
my experience with anti-motility agents is fairly in the acute setting, aside from the tramadol that I usually give IVs. Sometimes when you give things like Imodium, you could abruptly slow down the system. And I've had situations where I've given that and the patient went into obstruction. But so I'm a bit careful. So I just use postoperative tramadol I use to slow down. Then over time, it usually solidify.
Yeah, you're already using an antimotility because canoped cause constipation anyway. What I also see is that giving proton pump inhibitors, PPIs, also helps to decrease GI secretions, because for some patients they really have a lot of problems with the food and electrolyte imbalances, and if we don't have a proper stomach device applied there, it now makes the whole feel messy. You now start to be dealing with peristomal wound infection and breakdown, which will now further worsen the mobility. Bear in mind that it doesn't have proteins to help in wound healing. So I think that's one other challenge that we have to consider. And then going forward down the line now, what will now be the plan of action for this patient? If you get the histology reports, if it comes out to be malignant, what will be the line of action? If it comes out to be inflammatory bowel disease, what will now be the line of action? I think we should be thinking ahead in that.
Yeah, you just brought in a further scenario, particularly with the output, the stomach output. You want to know if it's high output, which is anything more than 500 mils in 24 hours. If it is, then you have to replace that concurrently. But again, with the socioeconomic status of this patient, that like you already said, it would be cheaper for you to get loperamide, 2 milligrams, than to get proton pump inhibitors, because I'm sure the proton pump inhibitors will be more expensive. But loperamide will help, and you can actually titrate it. You know, if you give 2 milligrams or 4 milligrams or 8, you can titrate it to ensure if the patient does not have a colon, very unlikely that they will go into full-blown obstruction, because it's an ileostomy you are dealing with. It will help to reduce the volume and the firm up the effluent, but not completely block the patient. So I will still be in favor of using low dose loperamide, and you gradually titrate it up and see where you get your balance, because Imodium is far cheaper than your cholesterol or any.
Yes, can I make a quick comment, a question about regarding the ileostomy?
Yeah.
Can I ask exactly, Dr. Numa, where did you place the ileostomy for these patients?
Right iliac fossa.
Okay. Yeah, because again, having interacted with a number of surgeons, some people actually have issues. I know when I was in training, they used to tell us about the stomach triangle, the lower stomach triangle bounded by the anterior spine, the pubis tubercle and umbilicus on either side, and the upper stomach triangle bounded by umbilicus, anterior spine, and the midpoint of the costal margin.
Yes,
yeah, but now, especially interacting with stomach nurses, they insist that that triangle makes things worse for patients in the long term. And they feel that just a general rule of thumb is to use a landmark where you have your stomach 3 finger breadths away from the midline wound, and then 1 finger breadth above or below the umbilicus, depending on where your stomach gets to reach properly. So I think ultimately placing the stoma will depend on a number of factors, but the most important is that it shouldn't be under, it should allow the stoma to come out without tension. It should be away from the wounds and bony landmarks and any other anatomical landmarks on the umbilicus. You should be able to pass in at least 2 or 3 of your fingers. That again, that's debatable because 2 of my fingers is probably smaller than the average surgeon's finger in there. So there's always that debate. So I feel ultimately we shouldn't be too dogmatic about specific sites to put in a stoma. And that's my own experience of late.
Yeah, about that stoma's sighting, the best thing or the standard practice would be for you to mark the patient before surgery, and with the patient standing. No matter what your anatomy is or the landmarks, if the patient cannot see the stoma, it's useless. So for patients that have a big abdomen, when they lie down, you see the abdomen will flip back, and then you're going to get a wrong sighting. But for this patient that is an emergency, then you just have to hazard it. And the key is, as the higher it is, the better. So that if you end up with a big tummy and the stoma is on the redundant part of the abdominal fold, then you're not in difficulty there.
Yeah, exactly. Yes, sir. Exactly the point I want to make, because again, the dogma had always been to put the anilostomy in the right iliac fossa, which is in the lower. But for a patient who, not this patient, but for a patient who is obese, by the time the patient now gets to recover from surgery, is now sitting and standing, the stoma is now apparently not visible to the patient.
Yeah,
So
yeah.
probably it's actually put it in the higher location.
Yeah. Thank you. Dr. Kunle, okay. You have your hand raised.
Thank you, sir. Good evening, everybody. Thank you, Dr. Nemo, for the presentation. I'm sorry I joined late. I was in another meeting, but I did join at a point where I saw the postoperative photos of the bisected specimen. And the first thing that came to my mind is UC with pseudo polyps, as Dr. Eguari has said. And I just want to mention a few things. I have a little experience with UC. Like everybody has said, less is more. But less can sometimes be subtotal colectomy, in different cases. If I had to operate, well, colorectal surgeons will use all sorts of scoring systems before going, through love and beats and all that. But if I had to operate on the patient and I got in there, and I saw perforation, it's likely that I'll do a subtotal colectomy. If I got in there and I saw gangrene, it's likely that the least thing that I will do is subtotal colectomy, because if you were to leave any of those things behind, the patient will almost certainly go down. So I didn't catch the first part of the presentation, but from the subsequent discussions, I want to imagine that's what Dr. Enemo saw, and maybe that was the right decision to take out the colon. But if none of those are there, then I think what a lot of colorectal surgeons will do these days is to defunction the entire colon, just vent it, usually through a loop ileostomy, so that would be that. Then if you had to do a subtotal colectomy and you had to leave mucosa behind anywhere, whether it's malignancy or not, if you have to leave mucosa anywhere, one risk you face is mucosal formation, infection, and all that. You could diatomize the mucosa, do something to ablate it, and that diathermy is available in most hospitals, however old. The use of loperamide or other things to slow intestinal transit immediately after toxic colitis sometimes it requires judgment, because sometimes there is backwash ileitis. You well, in the intestinal failure unit I worked in, we initially prefer that everything went out. Obviously, the patient will be on TPN for nutrition and all that. And then after a few days, you start to slow down the intestinal transit. The idea of using intravenous albumin in these situations, I personally am a bit concerned about that, because the low albumin in this situation is actually an inflammatory marker, not a marker of nutrition. Albumin follows the severity of inflammation, especially in intestinal failure patients. Sepsis, hypoalbuminemia. You control sepsis, albumin goes back up. You know?
Yeah.
So TPN maybe if available, but if it's not available and you're sure you haven't left any perforation behind, then as soon as possible, some form of enteral nutrition. In our unit in Cape Town, we tried something and we wrote it up, which is to collect everything coming out from the ileostomy, you know, depending on where we put it, and we reinfuse it. We would reinfuse it into the small guts. So we did that a lot. We'll take it out, sieve it, reinfuse it. That's if you don't have TPN. And also if you don't have access to a dietitian, the effusate from the ileostomy is probably the best thing, because it has the electrolyte concentration that this patient's body is used to, digested food and all that. You could pass an NG tube in and infuse it slowly, you know, and the patient will not vomit. And after a few days, you put up loperamide. In our unit, we were happy to go as high as 64 milligrams, maybe not in a patient like this with a full small bowel, but intestinal failure, loperamide has a very good therapeutic window. It's a very safe drug, and it could be very useful as long as there is no backwash ileitis. But for nutrition, anywhere in the world, you can collect what is coming out and reinfuse it into the gut. That way you won't have to look for, you know, TPN and all that. That's it, sir. Thank you.
Thank you so much, Dr. Oke. I had another hand up. Is it Dr. Ndukuba? Yeah, Dr. Ndukuba Elekwe. You had
Yeah.
your hand up.
Thank you, sir. My concern has been addressed. Thank you. I've lowered it.
All right. Thank you so much. Yeah, so again, I concur with Dr. Okede, particularly with the issue of administering albumin. If we know that these are low molecular weight structures, if you're giving them in the face of inflammatory or infective or septic conditions, they just leak out. You know, so you're giving it's leaking out, and to consider somebody who couldn't afford a radiography to be buying albumin that is just going to be leaking out, you know, but thank God this guy, he's already taking soup. I mean, enteral nutrition is superior to any parenteral nutrition any day. So if he's doing that, then with a nutritional advice, they could optimize his nutrition that way. I think Dr. Olasi is saying kindly fill the attendance register.
Yes, sir. I think there's some questions in the chat that we may not have attended, sir.
Okay, let me see. No, there was a comment by Dr. Ben. He said, I appreciate the predicament of the managing team. Patients unstable, as the patient is unstable, peritoneal, peritonitis, severe hepatic flexure adherence, etc. I wish it was possible to just pull out the ileostomy, control the sepsis, take a biopsy, and come out. I can guarantee you that going into the abdomen again after the histology is out may be nightmarish because the Hartmann's remnant may need to give way. to APR. Yep, I agree with you. But again, if you part of the history was that this man had a perforation at the mid transverse colon. So rather than trying to close that, you might just bring that part out either as a loop colostomy, or if you wanted a specimen for biopsy, then you can resect that segment and then bring out a double barrel or a mucous fistula and then end colostomy on the right side. Yeah, it definitely is going to be difficult. But then the other worry you now have to have in this patient who has a friable colon, has hypoalbuminemia, and then you have a closed stump on the other side, you also have to face the risk of a rectal stump blowout in this patient. I don't know, is that something that is worth considering? Is that a consideration or a worry for anybody? Or what's our view about that?
Absolutely.
Yes, absolutely, sir. I agree. Typically, what I prefer to do is if I do a Hartmann's, I would try to irrigate or wash out the lower rectum. Whether you now use saline or some antiseptic is now debatable, but at least to keep it clean. And also put in a large catheter, Foley catheter, or if I have available, a mushroom catheter, just to drain the area in there. Of course, if it was an IBD surgeon doing this and it was done in a setting where things were not being so rushed, what they tend to do is to hook the rectal stump to the fascia, soft fascia, so that if there is a blowout, it's better for it to blow out to the wound and be treated as a wound infection, rather than to blow out the peritoneal cavity, and then you have to start thinking, should I go back or not to reoperate the patient?
Yeah.
But I think for me, I'll clean out wash out the lower rectum, put in a catheter, and anchor it to the perineal skin. But if it's IBD, then make it soft fascial Hartmann's.
Yeah, so I would agree with Dr. Adeyeye on that. But in the setting that Dr. Enemo operated in, I think maybe the best thing is just to bring out a mucous fistula and let anything that happens happen outside, because the patient obviously doesn't have money, may not be able to afford the next surgery.
Yeah.
So, sorry, Dr. May I ask a question, please?
Yes.
If you intend to irrigate the distal, that's the rectum, from the anus, how often do you do that?
In fact, that's what I wanted to say now. Do you really, all you need to do is just to put in a rectal tube. I don't think you should be irrigating just for now, just to temporize that rectal stump. Just put in a rectal tube that takes the pressure away from the rectal stump, and hope it helps to mitigate that risk of the rectal stump blowout. Because if you are pumping in a solution into the rectum, that could inadvertently actually blow the stump.
Yeah, sorry, I think we need to clarify that. What I meant by is intra-op before putting the tube.
Yeah.
Yes, it's before putting the tube. So once we created the stump, I would clean the tube and then put in rectal stump, because sometimes you have patients with feces within that area. Because the rectal tube isn't 100% foolproof, if peradventure there is now a blowout, you may have less fecal contamination from the blowout. At least that was the teaching I was given in there. But it's not going to be a continuous irrigation of rectal tube after the procedure.
Yeah. Agreed. So any other comments on?
Yeah, I have one more comment to make regarding pathological diagnosis. Because right now, what will determine the long-term treatment for this patient is pathology. And I think because of the fact that we are seriously entertaining diagnosis of IBD, I feel that this is a situation where it's best to get at least 2, if not better, 3 pathology reviews for this patient. bear in mind the fact, with all due respect to our pathology colleagues in there, and the fact that we don't have as much experience in the diagnosis and treatment of IBD in our setup, like in the Western world. So that we can get the appropriate call for these patients, that is this truly IBD, and is it truly ulcerative as we think, and is there any evidence of dysplasia or even neoplasia within these sections in there? And so I think it's a very important point that we should put in mind here.
Yeah. Okay. The other question I want to ask is, what's our view about dissecting a specimen before it gets to the histopathologist?
Well, if I may answer that, it depends on the prior discussion with the pathologist. So let me extrapolate to breast, and I'll come to rectum. So when I used to do my mastectomies, I would tag the margins. I'll use the SLD nomenclature. I'll put a short suture superiorly, a long suture laterally, and a double-stranded suture at the deep surface of the specimen. And then I'll take the lymph nodes I see separately, so that I'll be sure that the margins are properly tagged, and whatever I think is axillary fat is also separately sent to the pathologist for assessment. So, but I had to have a discussion with the pathologist before doing that, so that they will know that this is actually what I want, because some pathologists don't want you to mess up with the planes. So I feel that it's best to have had this conversation beforehand with your regular pathologist, whether they want you to bisect or not. Some pathologists say, don't touch the specimen, just make sure it's clean, it's not going to fix the formalin as soon as possible. Some will say, we don't mind, as long as you mark the margins and you let us know that you bisected it. So, but at least that's been my experience with pathology and bisecting specimen.
And that's been my experience to Dr. Madiye. I think it depends on your pathologist. We used to bisect our colon specimens, and pathologists will tell you, look, it's affecting our staging. But pathologists tend to not want to have to deal with poop. So once we've done that, what we do is to open up the staple lines on both sides and allow the poop to come out. If there's a lot of poop, you just irrigate with saline or something, but you otherwise leave the specimen untouched.
Okay.
What's your experience?
One of my queries there is, in staging these patients, whether this patient is going to be a stage D, or 4, a patient that's had a perforation. Once you bisect and maybe the perforation is on the line of bisection, it's difficult for the histopathologist to then confirm if there was a perforation, particularly in tumors. If you have adjacent perforation, they want to know, they want to see that specimen. So you'll be better off really not to disturb the site of the crime scene or something like that, so that the evidence can be there for them. But again, it depends on the pathologist. But I'm just saying, if you have an antimesenteric perforation like this patient had, and Dr. Nemo bisects it on the antimesenteric border, he will go through that perforation. So the histopathologist will not be able to see where the perforation is. And by definition, if you have a perforation close to a tumor, that upstages it,
The perforation was close to the tumor. But like Dr. Oke has said, and as well as the pathology at Enugu here, at least 2-3 of them would usually advise that we help them to, especially use breast and colon, to wash through the barrel and then bisect the anti-mesenteric border and wash again, so that the formalin could fix, because there's been complaint about not fixing the samples properly. So by the time they are handling the sample, they would have undergone some degree of ischemia. As a matter of fact, in breast, after tagging the margins, what we do is to bivalve at several points, just like you do some slices of bread, getting it down to the margin of the deep fascia, and then leaving it at that particular point from the skin, so that formalin to get into the specimen at various points of the slices. So that's been the practice here, so that they could properly fix the specimen. They've had situations where samples were submitted to them several days after, and they have them, some of them ischemic and gangrene from some instances.
I think apparently it looks like there is no consistency in approach in here, and that may call for a need for guidelines or even a position statement
Yes.
between the societies on how they want us to approach specimen in there.
Yes.
And I think it's something that can serve as guidance for us.
Yeah, I think it needs further studies, because from what I know, the cells are lipid-based, cell membranes are lipid-based, and formalin is very, and it permeates, the cell membranes very easily. So, yeah, once you fully immerse the specimen into formaldehyde, it will fix it, because it will penetrate the tissue, because these are lipid-based cells. That would be I can understand them not wanting to be swimming in feces, so you can open one end and just flush it out. That I can understand that, but to be bivalving, you're really just disturbing the specimen. They can't give you a clear description of what you give them. And once you put it in formalin, it shrinks. I mean, you can imagine something you bivalve. Once you put it in formalin, it really just disfigures that way. And it's difficult to really give you a macroscopic description of what you've given them. And then the other thing they do is to stain the specimen. So when they make slices, they want to see the stained edges. Again, it all depends on the pathologist, but where in my institution, you don't touch specimens, you don't disturb the best specimen. It's just.
And another thing, sir, with specimens in Nigeria, when I was the chief of surgery at Lagoon, we had issues with specimens because pathology will tell us, oh, specimen is autolyzed or degenerated or something, degraded, and had to look into it. One interesting thing was, okay, so we had to look at several processes, which is how do you prepare the formalin to start with? People were not preparing to 10% formalin or something, I can't remember. The other thing is the idea that you just need to put just enough formalin on the specimen. That's a problem that I've noticed in a number of hospitals I've worked in Nigeria. The specimen is supposed to disappear completely inside formalin. And before you leave the theater, I mean, if you were to put a colon specimen in a bucket filled with formalin, it will probably absorb 20 to 30% of the volume before you leave the theater. And it hasn't even completely fixed. But people put for example, you put a right colectomy specimen in a bowl that's supposed to contain maybe 500 meals of rice on a good day. You're not going to get a fixed sample. And I agree with Dr. Egware about the formalin being avid for cell membranes and all that. Whether we open the specimen or not, if the quality of the mixture is good, the volume is good, it will fix. So maybe the responsibility of the surgeon too is to look at the entire process in our facilities and make sure that everything is well from the time the specimen leaves the patient, which should be the start of the ischemic time, to the time it gets to the pathologist. Thank you.
Again, if I can make a comment on that, that's another challenge we have because
Mr. President, just before how are we doing with time?
I think we probably have 10 minutes or so.
Okay, good.
Maximum 10 minutes.
Okay.
So what I was trying to say was that it's a challenge because the surgeon, while you're operating on a patient, still has to start thinking about formalin process, which again is supposed to be the responsibility of pathology and the preoperative and staff. But the patient is your patient and you still have to take those decisions, and those things, no matter how minute, will affect it. I know there are sometimes when people even find out that there's not enough formalin supply in theater, and they now mix formalin with normal saline.
Wow. No, you see, like where I work, these buckets, they come in, they are prepared, they are sealed with formalin inside. So you select the size of your bucket based on the specimen you are going to put inside. And it is open there, the formalin is already inside to a particular level that is, and you put it and seal it back again immediately.